I welcome everyone to today's endocrinology grand rounds. It was certainly a challenge getting here with all the water everywhere. So we are very pleased to have one of our own faculty present today. Dr. Swapna Deo will be presenting. She graduated medical school from St. GS Medical College in Mumbai, India, and did her residency training at Cincinnati, and then took a short trip down to Louisville, where she finished her endocrinology fellowship here at the University of Louisville. And she has since then been a clinical assistant professor in the Division of Endocrinology. She has been an excellent clinical endocrinologist. She has also been a great teacher. She does attend endocrinology clinic once a month, and also has presented every year at the endocrinology grand rounds. And each time she brings up some interesting and challenging topics, which are very useful for both practicing endocrinologists and also our fellows as they make up part of our boards and other things. So we're very pleased to have her present this new topic for us, coronary calcium score and the endocrinologist. Thank you, Swapna.
Thank you, Dr. Moshanganam, for the kind introduction. So good afternoon, everybody. Thank you all for being here, those in person and those joining online. I am excited and thankful, as I am every single year, to have this opportunity to be able to present the grand rounds here. The topic of the day is coronary artery calcium score and the endocrinologist. I wanted to share this picture of my recent vacation to this beautiful place, which was definitely out of the world, and I thought I needed to share it with everybody before we get started. I have nothing to disclose. Let's start off with some cases. A 59-year-old white man physician presented to the office for evaluation of primary hypothyroidism. He has prediabetes, renal calculi, osteoporosis, sleep apnea, and a very strong family history of cardiac disease. Father died of heart disease at age 52. Paternal grandfather died at age 49 of coronary artery disease. In his words, he had outlived his family members more than he had thought. His BMI was 20.96 kgs per meter square on presentation. His lipids, and this was, as you can see, way back in 2015, seemed pretty okay. Total cholesterol of 127, triglycerides 139, HDL 25, LDL 74, and lipoprotein A that was not concerning. Should he be on statin therapy? We have case 2. A 74-year-old African-American woman with a BMI more than 30 who is being followed for toxic multinodular goiter and hypertension. Her fasting lipids were checked, and they were as below. There is no family history of heart disease, no diabetes in her or her family members. The triglycerides were somewhat elevated at 202, total cholesterol at 214, a low HDL of 28, and an LDL of 146. She's not on any cholesterol medications. Blood pressure was well controlled on antihypertensives. Again, the question is, should she be on statin therapy? So I have a live poll here. I know we've not done this before, and I thought it'd be interesting. So if you wouldn't mind pulling out your cell phones and trying to do this, you can go to slido.com, put this code in, and if you can answer the question, we'll see how well it works. You could. It's easier the other way too. You don't have one? What about you, Ruel? I just noticed that the 0 and the 26 to 50 somehow got flipped.
Yeah, we're gonna be interactive, so I'll do it.
We'll give it about 30 more seconds. We have 6 responders so far. Yeah. You can do it. Yeah, everybody can do it. The online participants, you can do it as well. You just need to go to that slido.com, put that hash 3421864 and see if you can answer it. Okay, let's give them another 15 seconds. All right, so as you can see, about a third of the respondents, and I know we don't have a high number, have never recommended or ordered a coronary calcium score. And I didn't pull in here, but I would be in the more than 50 category. About half of them, 50%, have ordered 1 to 25. So that's some good numbers there. So let's start off learning what is coronary artery calcium. So calcium deposited in the coronary artery is basically the coronary artery calcium. The deposition occurs simultaneously with the progression of atherosclerotic plaque and is thought to be due to smooth muscle cell death. It initially begins as a microscopic calcification of 0.5 to 0.15 micrometers, and it can grow in 3 millimeter calcium sheet deposits. It usually occurs in the intimal layer. However, the younger patients who have soft plaques, who have less of a calcification, do not usually have that coronary artery calcium elevated as compared to the older patients. On the right here is CT scan that from the MESA study, which is one of the big studies, multi-ethnic study of atherosclerosis, which shows, and I'm not sure if, oh, you can see it, which shows this coronary artery calcium in the form of white spots here, bright white spots, which indicates the calcium in the left coronary artery. So now that we know that there is calcium in the coronary arteries, how do we quantify it? The CAC score, or coronary artery calcium quantification, is done by a few different methods. The most common method is the Agatston scoring. For this, breath timed CT data set is used using 2.5 to 3 millimeter slice thickness. So the patient is asked to hold their breath and they get the slice thickness of that grade. And that data set is used to calculate the score. The area of calcified atherosclerosis, which is at least about a millimeter square with a Hounsfield unit score of more than 130, is multiplied by what is called as a density weighting factor. And that weighting factor is determined by the degree of the elevation of the Hounsfield unit. So 130 to 199 is a factor 1, 200 to 299 is 2, 3 and 4 as mentioned. And that's multiplied by the area of the coronary calcium to give a score. This is usually done in 4 major coronary arteries, and then the CAC is summed up for the entire coronary artery tree. One of the limitations to be noted for the Agatston scoring is that it does not differentiate between plaque volume and plaque density, because it's doing that multiplication factor. It kind of gives you the whole number. And why is that important? Because higher density plaques have actually been shown to have decreased ASCVD risk due to the nature of them being more stable. And although CAC score reports don't usually show pictures like these, like a DEXA scan would, this is how it would look when you get a coronary artery scan ordered. The report's actually in there as a total score, and each of the artery score, but the pictures are not in the report. So this particular CAC score report shows that the left main had a score of 9. LAD was pretty high. As you can see, lots of calcium, lots of deposits here with a score of 384, and the left circumflex and RCA totaling to a total score of 523. So then how do we know what score is good and what score is bad? So CAC score is categorized into different categories, with a CAC score of 0 indicating no identifiable disease, 1 to 99 being mild, 100 to 299 being moderate, 300 to 999 score severe, and more than 1,000 indicating extensive or severe disease. Different cutoffs are used in different studies, with some studies using 0, 0 to 100, 100 to 400 and above, and such. What is incidental CAC, or incidental coronary artery calcium? These are found on non-gated CT scans, which are done for other reasons, or sometimes chest x-rays as well. The Society of Cardiovascular CT and Society of Thoracic Radiology requires that the presence, severity, and extent of CAC be reported on all non-contrast chest studies. However, there's not much data on how to score these CAC scores. Knowing that this positive coronary artery calcium is helpful, but there's not a way to actually quantify it. You could use a Gatson score using special software. Sometimes a visual estimation is used, or ordinal scoring, where you can use absent of 0, mild, moderate, severe, 1, 2, and 3, where mild is usually less than a third, and so forth. With the newer AI algorithms, the automated deep learning algorithms, you could identify and accurately quantify incidental CACs on some non-gated CT scans. So why is coronary artery score, calcium score important? So CAC scores correlate strongly with coronary atherosclerosis. They are a very important certification tool used for prediction of atherosclerotic cardiovascular risk. They're usually interpreted in conjunction with, so along with other tools that we use already for ASCVD scoring to determine therapeutic decisions. The MESA study, like I mentioned before, the multi-ethnic atherosclerosis study, it showed that it can be a very strong marker among individuals with family history. Also to be noted is a CAC score is a continuum, which means a higher score usually predicts higher atherosclerosis burden. And in that same vein, a score of 0 is a stronger predictor of low ASCVD. So this is the usual tool that we use when we calculate ASCVD risk, and I hope most of us are doing that. In the EPIC, at least at Norton's, it is a .ASCVD phrase, which means that if you put .ASCVD, it'll calculate the score for you right there. Let's go back here. So in this ASCVD risk estimator, and if you don't have one of those dot scores ability, you can go to this website and put in your demographics, race, your systolic blood pressure, cholesterol, systolic and diastolic blood pressure, and the cholesterol numbers with a few other personal history markers, you could calculate your ASCVD scores. This is a much more interesting calculator, which was based off of the data sets out of the MESA study. This incorporates the calcium score into the algorithm. So let's try this one out. So I'm going to have a female, 48 years old. Let's put a coronary artery calcium score of 200. Let's see if her race is African American. She doesn't have diabetes. She doesn't have history of smoking, but she does have a history of family history of heart attack. The cholesterol score is not very concerning, maybe 210, just a little bit high. HDL is, let's do 28. Systolic blood pressure 120. And maybe she's not on any of the antihypertensives or lipid-lowering medications yet. So as you can see, using this CAC score, her 10-year risk of coronary heart event has suddenly gone up from 2.4 to 8.8. So the bottom one is without the CAC score, and the top one is using the CAC score. So as you can see, the risk has increased substantially. Let's go back to learn more about how we can use this. Okay. So there is an incremental benefit of the CAC score. In this MESA study, when they looked at about more than 6,000 asymptomatic males and females without baseline cardiovascular disease, and they were followed, they found that compared to those with, compared to a CAC score of 0, the hazard ratio for a coronary event was 7.7, which is 7 times as much for those with CAC scores between 101 to 300, and 9.7 for those who had a CAC score of more than 300. So the higher the CAC score, the higher the likelihood of a coronary event. So why do you want to get a CT CAC score? Why not something else? In an asymptomatic patient, a CAC imaging is preferred over CT angiography, which is a CCTA, because it requires minimal preparation, minimal patient time. It has a radiation dose that's equal to a mammography dose or even less. It's low cost. It's non-invasive, so no IVs, no dyes. You don't have to check renal functions. It has specificity for calcified plaque, which directly correlates with the plaque burden. And it's a risk predictor with the ability to provide a strong basis for medical intervention. Also, it can be used as a follow-up tool. Here's one more. So for those who have ordered a CAC score, do you know how much it costs? You can go to your slido.com again. The number's the same. All right, well, just take it from there. We have 4 respondents. Oops. It's supposed to give me the cost. There you go. Okay, I have all kinds of ranges. And I love this because then I get to tell you what it is. So not sure, which means, probably didn't get an opportunity to order one. 99 to patient, more to the health system. I think that's an interesting answer. And then you have anywhere from 80 to 500. So in Louisville, the cost of CAC score was the lowest CAC score cost was $50 at Clark Memorial Hospital. They have since stopped doing the CAC scoring ever since they got bought by Norton's. Norton has a CAC score cost of $100. The standalone systems, which are Priority Radiology or Heartland or one of these, they cost about 70-ish. And then at Baptist, I've heard it's 150 or more. So what are the drawbacks of CAC score? It does not provide information about lumen patency because it's just a CT calcium overlap. It's not giving you the actual the lumen patency or the likelihood of stenosis, the degree of stenosis. It does not detect non-calcified plaque, which can be an issue in the younger patients who have soft plaques, or even in older patients if some of the plaques are non-calcified. Specialized reading software is needed to quantify the calcium score. A lot of the places in the country in US do not necessarily have that software, so CAC score may not be available. And there's some radiation exposure, but it's very low. So this is kind of an extensive chart, but I think it's kind of important. It shows candidates who might benefit from knowing their CAC score is 0. So in your practice, you often have patients who are reluctant to initiate statin therapy, and they would like to know whether they have a high risk and if the statin is going to benefit them significantly. In those patients, knowing a CAC score is 0 would be helpful to delay the institution of statin therapy. Patients concerned about need to reinstitute statin therapy after discontinuation for statin-associated symptoms is another category. Older patients who have a low burden of risk factors but want to know, well, should I really be on statin? And then we have this kind of a middle category where you have middle-aged adults with a 10-year ASCVD risk of 5 to 7.5%, which is not considered to be very high. However, they have other factors that increase their risk, and if they would like to know if they should or should not be on statin, knowing that a CAC score is zero would be helpful in risk stratifying them in the lower risk category. So if a patient is in immediate risk and the risk decision is uncertain, you do a CAC score, it's okay to withhold statin unless they have more concerning factors like smoking, family history, diabetes mellitus, etc. So in your practice, who would you screen for a CAC score? So CAC scoring is used for asymptomatic patients, usually more than equal to 40 years of age, who have ASCVD score by that calculator that I showed earlier, which is intermediate to high risk, so 7.5 to less than 20%, to guide either the decision about starting a statin or the treatment goal or the intensity of statin to be used. Consideration of aspirin therapy may also be decided based off of some of this information. Patients with borderline elevated ASCVD risk, which is 5 to 7.4% 10-year risk, who have a family history of premature vascular disease may also benefit from knowing their CAC score. So in this Heinz-Nixdorf recall study, there were about more than 4,000 participants without known coronary heart disease who had CAC testing done, and they were followed for 5 years. They found that the CHD event rates were highest in the CAC scores more than 400 at 6.8%, and much lower in the 100 to 399 at 2.4, with CAC less than 100 being 1.4. Who should you not screen? Very low ASCVD risk of less than 5% may not benefit from getting a CAC score, or very high CVD scores of more than 20%, as it may not alter your treatment regimen, and they probably already are have high intensity statins on board with stringent LDL goals, and they may not benefit from getting an additional CAC score done. However, sometimes if you have a patient who is hard to be convinced about the need for some of these medications, having the CAC score may actually reinforce their desire to adhere to the regimens. Patients with symptoms of myocardial ischemia are not the right candidates for getting a CAC score. Usually a CCTA is superior. While doing the CCTA, they actually do calculate the CAC scores as well. 16% of patients with CAC scores of 0 who are having active symptoms were shown to have non-calcified plaque on CCTA, and that's why when you have a high degree of suspicion, CAC's not the right route to go. In approximately 2 years of follow-up, 16% of all events occurred in those with CAC 0, and it's probably because these patients had soft plaque, which was not picked up on the CAC score. So here's some really telling charts about the CAC score in type 1 diabetic patients, where, as you can see in the graphs, cardiovascular events, male or female, are the primary cause of death in type 1 diabetes, making it pretty important to make sure that we watch these cohort of patients closely. In this particular graph, you can see in the incremental CAC scores, with the dark bar graphs being diabetes and the lighter ones being non-diabetics, for any given score, the diabetic patient has both a worse prognosis, where these are on the y-axis, the events per 1,000 person years. They have an incremental increase in the events, both with the incremental increase in CAC scores and as compared to the non-diabetics. The higher risk and worse prognosis. A third of type 2 diabetic patients develop cardiovascular disease in their lifetime, and 50% of the mortality is attributed to it. They also have other concomitant conditions such as hypertension, obesity, dyslipidemia, which all increase their risk. The optimal control of blood glucose has been shown to reduce the risk of cardiovascular heart disease by 15% and non-fatal MI by 17%. CAC scoring helps traditional risk stratification tools improve your treatment decisions, thereby reducing preventable events. As you can see, the CAC score of more than 1,000 has a very high likelihood of myocardial infarction incidence for 1,000 person years, but 0 to 100 being the lowest. So then what do we do? Well, statins have been shown to have a beneficial effect with a mean annual change in CAC score being much lower in the statin-treated group versus the no statin group. This is in spite of the fact that folks who are treated with statin actually have an increased calcium density, and because of the stabilization of the plaque, that's supposed to decrease the cardiovascular risk percent. However, even considering that, the percent increment with statin therapy patients is much lower than those who were not treated with statins. And then why is that important? So as you can see here, the progression, and I will go to this graph here in just a second, but if the progression in CAC score is more than 15% every year, it is considered to be significant. In the DCCT follow-up, they looked at about 1,000 plus individuals with diabetes who had received a coronary calcium scan. In this group, the mean age was much lower than the 40 that we had initially talked about, and a third of these patients had positive calcium scan. In another trial, which is the type 1 diabetes CAC score trial, you have 600 volunteers, again with a lower mean age of 37, who had about half of the men had a positive calcium scan, and a third of the women had a positive calcium scan. So what we're looking at is early calcium deposition, or the process of atherosclerosis being much earlier in patients with diabetics, which makes it even more important to screen some of these patients for preventable events later on. So if the progression is less than 15%, the prognosis of being free from a myocardial infarction is pretty good. So your baseline CAC score in that case does not matter. So even if you started with a baseline CAC score of 100 or 600, if it's not progressed in a year by more than 15%, then that's a good prognosis. However, if the progression is greater than 15% per year, then your initial CAC scan value will determine the likelihood of myocardial infarction. This is very well depicted in this particular graph, where you can see this top line up here, where no matter what your CAC score is, if the progression is less than 15%, your cumulative MI-free survival is pretty good. However, as you can see, your CAC of 100 or less, 100 to 400, and then as it keeps going up, your MI-free survival drops significantly because these folks had a more than 15% increase in the CAC.
This is also type 1?
This was, I think, all, I'm not sure. I think it was type 1, so. But diabetics for sure. So the hazard ratio for all-cause mortality for CAC score is higher. These hazard ratios are in diabetics compared to non-diabetics, and this is the rate of progression. So as you can see, there's a much bigger jump if your rate of progression is more than 30% in a year versus the 10 plus categories, but nevertheless, you still have a higher hazard ratio versus the non-diabetics if you have CAC progression in diabetics versus non-diabetics. Okay. So coronary artery calcium and hyperlipidemia. These values have been shown to be of a high predictive value and are used for risk stratification for the determination of treatment goals in high cholesterol. We know that the AHA, ACC cholesterol guidelines recommend doing a 10-year ASCVD risk estimation using pooled cohort equations as a first step to guide the discussion. Your scores are used to determine not only the initiation of therapy, but also the intensity of therapy and the treatment goals. As we saw earlier, the CAC scores were incorporated in the MESA calculator, which helps change some of these ASCVD risk scores, as you saw in our index patient, where the score went up from 2.8 to 8+. So this is a chart from the treatment goals for lipids per ACE guidelines. And we don't have to go through all of it, but as you can see, even the low risk category, your treatment goal is less than 130. However, as you get here in the extreme risk, which is folks with progressive ASCVD, unstable angina, in spite of your LDL being less than 70, or stage 3 or 4 CKD diabetes, your goals change to less than 55. You have in-between goals here, but less than 100 for mid to high risk and less than 70 to high risk in the high risk category. This graph here shows the effect of statin on the cumulative incidence of major adverse cardiovascular events, the MACE, depending on the CAC severity. So as you can see in these two graphs, with CAC of 0, with or without statin, the lines don't deviate much at all. So there is not much benefit to having somebody on statin if the baseline CAC is 0. The lines start to move, diverge somewhat for CAC scores of 1 to 100. But as you go to 100+ and more than 400, there's a much bigger divergence with folks treated with statin having a much better prognosis. This is a very busy chart, and I don't mean for you to actually go through all of it. I have it broken down a little bit, but there are guidelines about primary prevention by assessing the cardiovascular risk in different age groups and depending on different parameters. So let's go over just a little bit of some of these and figure out at which point do you really decide to get a CAC score. So between these at the low age group category 0 to 19 years, if you have a known diagnosis of familial hypercholesterolemia, they automatically get on statin. But for the rest of the categories, you have to, again, get your ASCVD risk assessed. And if your LDL is more than 190, there is no risk assessment. You automatically put them on statins. Again, if you have diabetes and your age is between 40 to 75, you have a moderate intensity statin. But somewhat here, I think you do have to get some more risk assessment tools, and that's where some of the CAC scoring will come into picture. So, like I mentioned before, if your ASCVD risk is between 7.5 to less than 20, that would be the group that you consider measuring the CAC. Where if CAC is 0, you get risk stratified into the low risk category. And if it's CAC more than 0 or non-zero CAC, you would probably favor statin, especially after age 55. There are some other cardiovascular risk enhancers, which include a family history of premature heart disease, persistently elevated LDL, CKD, metabolic syndrome, premature menopause, inflammatory diseases, ethnicity. Very interestingly, South Asian ancestry, of course, is a known high-risk ASCVD enhancer. However, this population has not been used when it was time to do the pooled cohort equation. So they're not part of the MESA calculator. With the MESA calculator has 4 groups: Hispanics, Blacks, whites, and Chinese, but no South Asians in the race category. However, we'll talk a little bit on the Masala study, which has looked at it a little bit more closely. Persistently high triglycerides are also a risk enhancer for heart disease or cardiovascular disease. And then some of these other biometabolic markers, which include CRP, more than 2, LP(a), more than 50, ApoB, and ABIs, which are low. Let's take a quick look at CAC and hypertension. Elevated blood pressure is a significant risk factor for heart disease as well. And I didn't know this, but prevalence of hypertension among adults more than 20 years in the US is actually 46%. Hypertension accounts for half of the cardiovascular events, and age-adjusted death rate's pretty high. So why is it important to risk stratify in this population? Because this particular trial, the SPRINT trial, showed about a third reduction in all-cause mortality amongst non-diabetic hypertensive adults who were at a high cardiovascular risk, who were intensively treated to a systolic blood pressure less than 120. So to determine your blood pressure targets, it's important to have your risk calculated. These two charts show you, again, how CAC can determine what your treatment goals should be in untreated mild hypertension and treated stage 1 hypertension. So if your CAC score is high, they are categorized into this, again, and we won't go through in detail about for each of these charts, but if your CAC score is higher and stratifies you into the high risk category, a much more stringent blood pressure goal is indicated. Where you can see that the high risk category goal is less than 130 over 80 versus a low risk where the goal is less than 140 over 90. And same here for the treated stage 1 hypertension, where CAC of 0 stratifies you into the low risk, and CAC of more than 100 puts you into a high risk. In this particular chart, as you can see, the CAC 1 to 99 is kind of a gray zone area where you might have some shared patient decision-making to be done. A little bit about the MESA, the multi-ethnic study of atherosclerosis. It found a significant difference between CAC scores and ethnicities. It investigated 4 of the ethnicities, as I mentioned earlier, and concluded that coronary calcification with non-zero or a Gaston score more than 0 was greatest amongst white race and least in the black race. Diabetic patients with high triglycerides were more likely to be white, and epicardial adipose tissue volume was found to be higher in diabetic patients who were white, and it was independently associated with subclinical coronary atherosclerosis. Also, there was a significant relationship between baseline CAC score and medication continuation rates for both statins and aspirin, which means that if you have a patient who seems to not want to comply with their therapies, having a CAC score that is elevated might convince them to stick to their, adhere to their medication regimens better. Obesity and CAC scores are also related, where higher waist circumference was associated with a lower CAC density. And the difference here is this is not a CAC score, it's a density. Lower CAC density, like I had mentioned earlier, actually has a likelihood of having more softer and unstable plaques. So the higher waist circumference, which is a risk factor for cardiovascular disease, as expected, is associated with a lower CAC density in both men and women, while a higher BMI, so more weight and circumference, was associated with higher CAC volume. In another study, obesity, which was defined by higher waist circumference and BMI, were both associated just with the presence of CAC. Obesity is a well-known risk factor for cardiovascular disease, as we already know, and Masala study results suggest that obesity could result in less dense, larger plaques, which are more likely to rupture. So the Masala study, which is the mediators of atherosclerosis in South Asians specifically living in America, found that hypertension was associated with CAC volume among men, while there was no significant association with CAC density in this particular study. Hypertension may result in larger plaques, no matter how dense they are. Impaired glucose metabolism and diabetes were also associated with CAC volume in the study, but amongst men only for some reason. So some of these results kind of just mirror the other results that I had mentioned earlier, but these were specifically in the South Asians, which were not included in almost all other studies. So it was also found that hypertension and HOMA-IR were inversely associated with CAC density, which means the higher your blood pressure, your CAC density is lower, which makes it more likely to rupture. And HDL was inversely associated with CAC volume. So the higher the HDL, lower the CAC volume, which is also kind of expected, but it just kind of confirmed those studies. Family history of cardiovascular disease was directly associated with CAC volume, showing a strong correlation, strong association between family history of cardiovascular heart disease and high CAC burden, which I think is very important because a lot of South Asians have probably normal appearing BMIs, but a family history of cardiovascular disease, it should be an indicator for them to be evaluated further for CAC scores, which could foretell a higher risk. So the Agatston CAC scores did associate with that pooled cohorts amongst the South Asians, even though they were not part of that calculated, the equation that was made. The study also showed that the PCE or the pooled cohort equations were associated with both CAC volume and density, and it could be used to refine some of these risks or better the risk estimates among South Asians. Again, as mentioned earlier, higher HDL results in denser coronary plaques, which are supposed to be more stable and therefore less likely to rupture. Just a quick overview about CAC in family history. Premature heart disease in men less than 55 and women less than 65 is an independent risk factor. Framingham score does not include family history in the equation. So one particular study, which was in the Cardiovascular Disorders Journal, showed that asymptomatic subjects with family history of early CAD had twice as much higher odds of having a CAC score above the 75th percentile adjusted for age and gender. However, the one shortcoming of the study was they did not really look at the likelihood of soft plaques, which can be detected with the carotid intimal thickness, CIMT. So how can we use CAC? We know that CAC is independently and strongly associated with cardiovascular disease, including strokes in almost all models of study. A 0 score carries a very low 10-year risk and should be used and could be used to down stratify a patient's risk based on risk assessment for consideration of preventive therapies. A score of more than 100 signifies an at least 7.5% 10-year ASCVD, regardless of age group, gender, ethnicity, and these individuals may be eligible for preventive therapies such as statins. CAC score strongly predicts risk with the same magnitude of effect in all races, age groups, sexes, and has been demonstrated to be predictive of cardiovascular disease in symptomatic patients as well. And that's a completely different topic, so we won't touch a whole lot on that, but it's been used in symptomatic patients as well. It has been shown to be a stronger predictor of cardiac risk than some other serum biomarkers, including high sensitivity CRP, carotid intimal thickness, ankle brachial index, etc. And it also showed improved risk discrimination and reclassification when you add it on top of the other traditional risk factors. So use of aspirin. It has been shown that aspirin has net clinical benefit for primary prevention in patients who have a CAC of more than 100, regardless of their ASCVD risk. So even if they have a calculated ASCVD with traditional calculators that's low, if their CAC is high, they would probably benefit from aspirin. The presence and severity of CAC has been shown to positively affect the start, which is initiation, treatment intensification, and patient adherence to aspirin, statins, antihypertensives, and exercise. If you have a CAC of 0, you could just wait it out and not start statin therapy and repeat CAC score in about 5 years, at which point a repeat assessment can be done, unless they have some factors such as diabetes, hypertension, smoking, or premature heart disease. So when do you do a follow-up? You could do a repeat CAC score in CAC 0 patients using baseline ASCVD risk if it is going to change your treatment recommendations. Like everything else, if it's not going to change anything, there's probably not much point in redoing it. So in patients with a low 10-year ASCVD risk, recheck in 5 to 7 years. If they're in the intermediate risk category of 5 to 10%, recheck in 3 to 5 years. And in diabetic patients, repeat CACs in about 3 years. There's not much advantage to checking CAC to assess efficacy of cholesterol therapies such as statins because it increases the calcified content and may actually slightly increase the CAC score. But while doing it, it is reducing the likelihood of rupture by making the plaques more stable. So going back to our patient, a CAC score was done for this patient. And at that time, his CAC score was 178. So definitely elevated. His BMI, as you saw, was well within normal range. The only, well, not the only, but one of the main risk factors that he had was the family history, along with his pre-diabetes. He was started on statin therapy, and his most recent CAC score, his most recent lipids showed an LDL reduction at 65, not much different from 74, but still lower. And then his repeat CAC score, which was done by I believe this one was done by his cardiologist, showed that his score has actually increased. So as you can see, his LDL probably needs further reduction. This one was 10 years.
10 years.
Yeah, he had been followed by the cardiologist all this time.
But are the machines the same?
Yeah, so that's a very good question. So probably not. I'm not sure if there's some discrepancy in the machine calculation, but the techniques are pretty standardized. I mean, it's 3 to 5 millimeter cuts on a gated CT with the breath hold. It was done at the same facility. So I believe the CAC score increased, knowing that he had the strong family history with fatal events. But I guess, yes, that could be a relevant question, especially if it's done at 2 different places.
The thing that changed
To less than 55.
that's late.
At the first event, so I'm sorry, for folks online, Dr. Mokshagundam is asking, so why was the CAC score done? What was going to be the change here? So for the first CAC score, the reason for doing the CAC score was initiation of statin therapy. No. He did not have any pressing reasons to be on it based off of his prediabetes and his normal BMI and no other risk factors. He was not a smoker.
But 10 years later, he did not have any
events, no.
So 10-year risk was 0.
On the statins.
Yeah, he didn't have any.
Say that question again.
If you don't have a heart attack,
yeah,
then risk is 0.
Risk for what?
For individual. And that means he didn't have an event.
Right.
So whether we prevented it or what we did, we don't know.
Well, we hope that we prevented it because we had him on statin therapy.
So this is where the whole question of what is, if you didn't have it, so if your risk prediction was 10%, 90% it wouldn't happen.
Okay.
Correct? So in individual patients, it's always very difficult.
It is difficult. So that's why you have these thousands of patients being studied.
statins are not going to reduce it. Like, statins are not going to reduce it by 100%.
Okay,
So if you had a 10% risk, it's going to go to 6%.
right.
That means it's
4% reduction.
so that doesn't look very impressive.
So again, for folks online, I think Dr. Moshanganam's point is you're not reducing the risk 100%. Your risk reduction is only a percent, a few percent less than what it was initially. So is it worthwhile doing it? And that's on a case-to-case basis. So that's a difficult question to answer because potentially just looking at the trends, he is now 69 years old. Now let me see. He is 59 years old now. So technically he could have had a fatal cardiac event.
So at this point,
So there's multiple things, and I don't have his exact dose of the statins. I would probably intensify his statin therapy if it's not already intensified. The question is, what would I do at this point? The second is if the statin therapy is already intensified, you have the option of adding another agent or two, including Zetia and PCSK9 inhibitors, though I don't know that there's lots of studies using those newer agents to see how much risk reduction can happen. But getting the LDL goal down would probably be one of the so yes, so CCTA, so one of the papers mentioned that in an asymptomatic patient, a CCTA done showing luminal stenosis does not necessarily indicate an impending MI. So would I do a CCTA in this patient? Not if it's asymptomatic. The cardiologists don't always do CCTAs either.
no, the cardiologist did this, right?
The CAC score, repeat CAC score. Not that I have noted. But potentially that could be a step. I have some patients that do end up getting a CCTA. The question is, would you intervene if the stenosis is not to a certain degree? So CAC score, from all the reading that I've done, is really not a tool to determine if you need stenting. It is used more for medical management and intensification of your medical therapy. This was a much more interesting finding, where this was a completely non-related kind of a investigation, so to say, because she was just seeing me for toxic multinodular goiter and hypertension. And we happened to have these, and I don't have her calculated ASCVD risk score, but she was recommended a CAC score based off of her obesity and her hypertension, and it was 1,473. So following this, she was started on the statins with a significant reduction of LDL from 146 to 65. Now, should she get CCTA? I mean, she's asymptomatic. I probably would say no. And the reason for not doing CCTAs is there are multiple. One is the cost. In an asymptomatic patient, you're subjecting a patient to a procedure that requires prep, IV dye, much more expensive, with no additional benefit if they're not having any other symptoms. So this is a picture of that. And just because I want to see if you can guess it, do you know which country this place is in? Or you can just type no if you don't know, or just a random place. Oops, sorry. That's an interesting one. All right. Oh, okay. I'll leave a few minutes for questions. So this is actually in Brazil. This is a beautiful Lençóis Maranhenses National Park, which I don't think you'll find anything like this anywhere in the world. It's just pristine, clear sand dunes over sand dunes over sand dunes with multiple lagoons. These are freshwater lagoons of rainwater that collects in here. And because there's impermeable rock underneath, it just collects there. And it stays there. You can wade in them, and they're less than knee-deep high. They rise and ebb depending on the season, and absolutely gorgeous sight. As far as you can see, that's all is around you, and very, very low tourists. So it probably might be just you around there. All right, thank you, everyone. And I shall open it to questions. That's the event code. Thank you.
So there's one question online.
Okay, let's see if I can get to a chat. Dr. Krishnasamy saying Greece. Okay, the question is from Amol Kulkarni. Well, I think there's a few more up here. Okay, Dr. Krishnasamy says for case 1, shouldn't he be risk stratified with a stress test? What kind of stress test? So, I mean, we have, am I supposed to be able to hear everybody?
Swapna, can you hear me?
Yes, I can hear you now, Dr. K.
Okay, sorry. So I put that in very early on before you and Dr. Mokshaganam went into the discussion, so you can ignore it. But basically, I thought if he's such a high risk and had premature CAD in the family, and symptoms sometimes may not help because symptoms only happen if they start, doing more. So I thought in those cases, they go into invasive testing rather than just relying on CAC. And especially he may have a lot of soft plaques. But then you said he's already seeing cardiology, and then you guys discuss more. Yeah. So
Okay.
So you can ignore that question.
All right. Thank you. And then we have a question from Amod Kulkarni, who says, which dietary supplements can help to improve CAC score? Will magnesium and potassium supplements help? I don't know of any. I mean, really, it's not any dietary supplements that are going to help improve the score. It's your lifestyle modification, making sure everything else that you normally tell a patient, you got to lose your weight, eat healthy, exercise, all that will help you over time. And also, it's whether that plaque is stable or non-stable. So there's still a lot of, I think, details that can be weeded out of for a CAC score, as I mentioned early on, that a Gadsden score, which is the most commonly used score, does not really differentiate between the density and the plaque area separately. It just gives you as a conglomerate score. So if the plaque is stable and more calcified, as can be seen post-statin therapy, it might do a lot better than having a softer non-calcified plaque, which is more likely to flick off. So I'm not aware of any dietary supplements that can help.
PCOS, those patients.
Dr. Moshe Gundam's question is, are there any recommendations for PCOS and NASH or other such specific tests, specific categories for, which one again? Transgender. I have to say, I do not know about any of those, any specific studies, but there is a lot of literature out there.
So in your first patient, was it because long-term statin treatment, it was more dense? calcification.
That's a good point. That could very well be, which Dr. Moshe Gundam says in the first patient was the increase in CAC score due to the statin therapy. Now, it was a 10-year interval and a 10-year 15% per year. I did not look to see whether it calculated out to whether it was a 15% increment. We can go back there.
200.
Was it 100 difference in 150? Right. So it was. So no, to answer that question, based off of that one chart that I had shown earlier, with or without statin, even considering statin's tendency to calcify the plaque and make it higher, the 15% progression just because of statin is unlikely.